So welcome to our next in the series of webinars for physio graduates and students, top tips for success at interview. And tonight's focus is on a neuro case study. Next slide, please, Alice. So just to say a little bit about us, we are, as you know, for those who've been with us already, we are the South East Coast Regional Network. We are a committee of NHS, charity and private physiotherapists, as well as physiotherapists that work at university based in the South East. And we are delighted to welcome you to our fifth in this series of webinars, which is going to have a focus on neuro. And we're joined tonight by Alice, Caroline and Kim, who are going to run this session. So thank you very much to all of them for joining us. As I've mentioned, this webinar will be recorded and all of our recordings are housed on our CSP website, the area for the South East Coast. Amelia will share this with you afterwards as well as some information that we talk about in the session. So you can get access to both the slides and the recording afterwards. We will be using both the chat and the Q&A function today. You'll note that you are all muted and your cameras are off. Sorry about that, but it's a way of kind of managing such a large group of you. So please use the chat for the interaction within the session. And if you've any burning questions that come to you as you go along, please put those in the Q&A. And Caroline and Kim will answer them as we go along, or if we want to hold it to the end for a bit of a bigger discussion, don't worry, we will get to it at some point, but they'll let you know if they're doing that. So I'm going to hand back to Alice now for her to get started. I hope you enjoy the session.
Good evening, everyone. Thank you so much for the introductions, SJ, and to the Southeast CSP for hosting these webinars and for having us to speak tonight. Thank you to Kim and Caroline. I think there might have been a few issues with Caroline, whether she's joined us or not, but they are my co-pilots, and as SJ said, hopefully they'll be able to navigate the chat and look at all your brilliant answers as we go along. And also thank you to all of you for joining us. I hope you learned something from this evening. This is the first time I'm doing a webinar, so hopefully we will all be learning together. Okay, so can everyone see the slides okay? All okay? So the plan for this evening is to replicate some of the questions you may be asked in an interview about a neuro case study. So I'm going to describe a neuro case study, which is actually a reflection of a real life patient that I'm currently treating. Then I'll give you a minute or two, I'll ask the questions and then give you a minute or two to think about your answers. And you can either jot them down at home on a piece of paper, or even better, we would love you to pop your answers in the chat. And as I said, Kim and Caroline will be checking that. And as SJ said, if there's any quick questions, then we could probably answer those within the chat. But if there are more complicated questions, perhaps add them to the Q&A and we can have a chat about those at the end. Give us a bit more time. Okay. So let's get cracking with our case study. So this is a typical referral we might receive in the community setting. So Mr. Smith is a 62-year-old man who has a right middle cerebral infarct. There's limited information on the referral, and that's very realistic. He has been discharged home a week ago after 2 months of stroke rehabilitation in hospital. He has significant difficulties with walking and limited use of his arm, and he lives with his wife and works as a business consultant. So that's the information we've got so far. So here is the first question I'd like you to think about. So it's a little bit of revision for your neuroanatomy and physiology. So first element is, what is a right middle cerebral artery, an MCA, and what is an infarct? Next section is, which areas of the brain may be affected with a right MCA? How might that person present with a right MCA? And whether we need any more information that you might require before your initial home visit. So I'm going to give you 2 minutes and take it away. Perhaps pop your answers in the chat if you have anything to think about.
Right, so I've got you on the timer for 2 minutes. I'm hoping you can hear me. Is that all okay? Yeah. Yes. Great. Right, so don't be scared. I can see there's 48 people in the observing Alice's amazing talk. So any answers to any of those questions, no matter how silly you think it might be or amazing you may think it's be, please jot it down in the chats, and it just helps us have an idea where you're coming from. You might know this inside and out and not need any help whatsoever, but Alice will obviously return with the answers, because that would be cruel to leave her suffering. So
we'll get to it.
Let's see. So first section. So the first question was, what is a right middle cerebral artery infarct? So you could start with maybe putting in the chat what you think an infarct is versus perhaps another form of stroke we might commonly see. Struggling on that one, parts of the brain, you don't have to be precise. You could go with front, middle, back. Doesn't have to be any more than that. And then we've got what you might expect to see. So I'm sure you've done some stroke rotations. Try and think, if you've got that patient that you know you're going to go and see and you've heard they've had a stroke, specifically if it's on the right side in that MC area, what might you expect to see? Anything coming through? So we've got some answers coming through. It's what we like to see. So we have got things about parts of the brain. So someone's chipping in with things like parietal lobe, temporal lobe. Very good. I can see that we'd expect to see a left-sided weakness. So any left-sided other problems we might expect to see. And they've put down here, very good, so reviewing all the medical notes, including referrals and handovers. Yes, crucial. Right, any more? Right.
Shall we carry on?
Right, so go on, Alice, you go to your answer sheet.
Okay, here we go. So thank you for your answers. It sounds like you're right on track. Brilliant. So let's start with the basics. So let's think about the central nervous system. So on the left here, we've got a picture of the cerebrum and the cerebellum at the back of the brain, and then those axons that travel down the spinal cord and coming down the spinal column. And of course, the spinal nerves come off this and feed into the peripheral nervous system, but we're not really focusing on that today. We're focusing on the central nervous system, the CNS. So in the middle picture, we can see the cerebral cortex. So this is the grey matter in the outer layer of the brain. And there's 100 billion neurons all crumpled up and packed into that area, into the skull. So we're looking here at the medial side of the brain, and we can see that we've got the deep structures within the middle of the brain, and that leads down into your pons and your medulla, which is essential for our critical living, our heart rate, our breathing, our blood pressure. And then the cerebellum at the back there, and at the bottom, which is responsible for our balance and our coordination, and also a role in learning. And then all those axons channel down into the spinal cord. So now looking to the picture on the right-hand side, when we talk about an infarct, this refers to a blockage within the blood flow of the arteries, and that causes a hyperperfusion of the brain tissues, as opposed to a hemorrhage, which is on the right-hand side here, which is where an artery ruptures, which causes bleeding into the surrounding brain tissue, as you can see in the diagram. Okay. So a little bit more detail now about the cerebral blood flow and what an MCA, or a middle cerebral artery infarct, actually means. We have the carotid arteries supplying the brain from the front and the vertebral arteries at the back. And together they form this amazing thing called the Circle of Willis. And it's a really clever design because it allows there to be blood flow even if one of the arteries is affected. So it becomes a kind of neuroprotective mechanism. However, you can see that the MCA, the middle cerebral artery, is not fully linked. So that's one reason why we see MCAs infarcts more commonly. The other reason is that there's quite a sharp turn when the blood flow enters into the MCA, and so this can cause a bit of turbulence, and that's another reason why we see more frequent MCA infarcts. So the diagram on the right shows the blood supply to the lateral part of the cortex, and the ACA, the anterior cerebral artery, predominantly supplies the medial aspect. So what I want you to do is just keep this picture in mind for the next slide, because as we move on, you will see how it impacts. Okay. So this again, the picture on the left-hand side shows the brain from the lateral side. So we can see the different lobes of the cortex. And if you were to put that previous diagram on top of this diagram, you can see how an infarct of the middle cerebral artery can have a large effect on the frontal lobe, the parietal lobe, the temporal lobe, and it also impacts on the internal capsule, which we'll talk about that in a moment. So of these cortical lobes, the frontal lobe is thought to be responsible for the motor areas known as Brodmann's area 4, or you might also know it as the primary motor area, also known as M1. I don't know why it's got so many names, but anyhow. And you can see that little picture of the brain in the middle has a red strip, and that is the motor area there. That is just before the central sulcus of the brain. So the rest of the frontal lobe, the prefrontal lobes, host our executive cognitive areas, so your reasoning, your decision making, problem solving, and personality as well. The frontal lobe also contains the Broca's area, which is the area for speech production. And in 97% of people, this is situated in the left hemisphere. So it's unlikely we would see speech difficulties or aphasia with our gentleman here, but he could be in that 3% where it's situated in the right hemisphere. The parietal lobe houses the primary somatosensory area. So this is that blue strip here, which is just behind the central sulcus. And it also has the associated sensory areas, which is more the perception of and spatial awareness in our body schema. And then the temporal lobe, a little bit further down, is more associated with our recognition of faces and objects. It's associated with learning and memory and auditory centers, and also the comprehension of speech. The Wernicke's area is in the temporal lobe. So again, this is situated mostly in 97% of people, again, in the left hemisphere, but it could be in the right hemisphere if you're in that 3%. The occipital lobe is predominantly for vision, which is more supplied by the posterior cerebral artery. So it's unlikely that we'll see disturbances with vision, as we won't probably see any issues with the cerebellum as well. So just at the bottom, before I go on to the diagram on the right, there's a really great little YouTube link here, which goes into a bit more detail about each cortical lobe. And I would definitely recommend having a look at it because it's quite interesting. So the picture on the right here shows the motor and sensory homunculus, and this is found on the cortex, and it is illustrating which neurons are associated with which different body parts in terms of motor and sensory, and they more or less mirror each other. We need to remember that the middle cerebral artery supplies the lateral side, and the ACA supplies the medial aspect. So we're more likely to see upper limb and lower limb motor and sensory impairments with an MCA infarct, whereas with an ACA infarct, we're likely to see upper limb sparing and mostly lower limb deficits. Okay, you still with me?
Yes.
Good. So these diagrams show the corticospinal tract, so the descending tract, and we just can see how it goes from that grey matter and then goes down through the deeper structures of the brain. through the internal capsule, which is this little bit here, which is really narrow. So you can see that if you even had a small stroke in the internal capsule, you'll probably see quite a big deficit in a patient's presentation. We can also see how this tract, the corticospinal tract, which is what we use for voluntary movement, crosses over at the bottom here in the medulla. So that's why you're quite right in your answers that we'll probably see some deficits on the left-hand side, the contralateral side to the area that the stroke has occurred. So I just wanted to highlight that these green axons here are white matter axons of the corpus callosum, which is how the two hemispheres of the brain link together. So it's really important that our brain knows what both sides of our body are doing, and especially with bilateral tasks. So I just wanted to highlight that to you. Okay, getting there. So this is a lovely diagram of a diffusion tensor image. It's a new type of MRI that actually tracks the molecules of water in the white matter of the nerve axons. And I put this in, I know it's to do with the diagrams to do with traumatic brain injury, but I just wanted to explain to you about how it's not just about the structures of the brain, but it's how they connect together. So whilst we might have that initial area that has been impacted by the infarct, that area might have ischemia, and so there may be synaptic death around that area, but also it's these connecting areas that also might have an impact. So the penumbra is the area around the core infarct that becomes hyperperfused. Now, if we get patients early into hospital after the first signs of their stroke, then doctors can give them thrombolytic medication, which can disperse the clot, and hopefully we can preserve this area that is around the core infarct. So it's really, really important that we get patients to hospital quickly. The other element I wanted to just talk about was diaskesis, which is the knock-on effect to the brain circuitry and function away from the original infarct. So we can sometimes see that there's a focal diaskesis, which is the area just anatomically around the region of the infarct. But we can also see a regional network, so you can see all these different pathways being affected. And then we can also see a connectional dyskinesis, which is where there's a big structural changes in the functional connectivity. So sometimes we see them between the corpus callosum. And just to add, there's a little YouTube link at the bottom here, which again talks a little bit more about the connectomes within the brain, and I would recommend having a little look at that. So in answer to the question, how might that patient present? You were quite right, and you said left-sided weakness, or what we call hemiparesis. You might see some left-sided sensory and proprioceptive loss if the parietal lobe has been impacted. We might see some left-sided neglect and perceptual issues. So that's where we might actually not even be so aware of the left side of the body. We see that more commonly in right MCAs than left. We might have some bladder and bowel involvement, so some deficits around there. We might have some cognitive issues. There might be some tonal issues. So just to remind you all, which I'm sure it's on the tip of your tongue, but spasticity is often defined as a velocity-dependent resistance to passive movement. And so it can be due to changes within the muscle tissue itself or an imbalance of the neural descending tracts. And quite commonly we see this a few months after stroke. So it might be that our case study is starting to present with a bit of changes in his tone. This can impact on his balance and mobility issues, and it can also, we might see that corticospinal tract damage affecting upper limb deficits such as typing, which might impact on his ability to participate in his life roles, such as going to work. And finally, in regards to what information we might need before our initial assessment, so I would always advocate checking with your senior first, and if there's anyone else in the wider team that is involved. You might want to talk about a discharge report. I think somebody might have mentioned that in the chat. So we can get lots of information from that, and it will save you time in your initial assessment. You might want to know who else is going to be present on the assessment, and definitely check with your safeguarding or lone working policies to see how your trust works safely. The bane of my life, parking. I always have to ask about parking because I'm always trying to check where I'm meant to be parking and where not. Okay, so on to the next question. So the question is, what questions would you ask in your subjective assessment? So what are the maybe normal subjective questions that you may ask a generic patient? And are there any specific questions for a patient post-stroke? And are there any safety questions that you would really want to cover? So again, you've got your 2 minutes, so off you go, and please do add any thoughts to the chat.
Hey team, I've got 2-minute timer on. Get your thoughts in. And like we said before, no silly answers. It doesn't matter what it is. It's silly questions, I mean, doesn't matter what it is, just go for it. So we've got, how physically active were you prior to the stroke? Any hobbies that were really important for you to get back to? It's really important. Good recent falls. What did your day look like before the stroke? Interesting, yeah.
That's a good one.
Any help at home? Yeah. Medical drug history, yeah, medications that are on. ADLs, work, childcare, all the really meaningful things. How we're doing? We're halfway. How are they washing, dressing before? How are they now? Any pain? Their function after discharge. Anything else around safety? We've got lots of the subjective info, specific question around stroke. Anything else around safety? So we've got stairs, access to the home. A few more around falls. Yeah.
Brilliant.
Any other concerns? Last 5 seconds. MDT involvement, any package of care. Red flags, interesting, yeah. Environment, good.
Right. Shall I move
There we
on?
are, 2 minutes.
Lovely.
Well done, team.
I had some fantastic answers there, things that I hadn't thought of, so that's great. So what I've done here is we've color coded this slide a little bit. So the green is what we might be asking a generic patient. So those are the things that you totally picked up on, your present condition, history of present condition, drug history, all that jazz. That's definitely something that we want to cover. But I'm going to focus a little bit more on the blue, which are the questions that you might ask specifically to a neuro patient. So as somebody said, balance and mobility, are they using any walking aids? Have they had any issues or near misses at all? And then we might ask a little bit more about their cognitive issues, such as have they had any memory problems, or have they noticed anything, so sequencing issues. So they might think they can't quite remember the stages of getting dressed properly or making a cup of tea. We might ask them a little bit more about perceptual difficulties. So have they noticed them knocking themselves on the left-hand side as they walk through a doorway? We probably want to explore pain. I think somebody put pain in the chat, so that's great. And we just want to be a little bit more specific and say, is that a central pain, so post-stroke pain, or is it a neuropathic pain, or maybe a musculoskeletal pain? So we want to be a little bit more specific about that. We probably want to ask about sleep, because sleep is so important for our patients to be able to fully engage in a rehab program. And it's important for emotional regulation, problem solving, memory learning, all those things. So we want to ask about sleep. We might also ask about bladder and bowels. So is it that they have decreased control of their bladder and bowels, or is it that they have decreased awareness of their bladder and bowels, or perhaps it's more of a functional incontinence, so they can't actually physically get to the loo. So that's something to be aware of. We want to ask about vision and hearing, and skin and seating. And seating is really important. I mean, from what it appears is that our gentleman is up and walking, but if somebody wasn't, you definitely want to have a look at their 24-hour postural management. So again, this is more heading back into the generic questions that you might ask, but ADLs and eating and drinking are especially important, so that person has the energy to engage in rehab. And then I'm just going to skip down now to the important questions. So you're quite right in saying falls. Has our patient had any falls or near misses? Do they have any swallowing issues? So are they coughing or having troubles with swallowing food and drink? And this could be a sign of dysphagia, where the muscles aren't working well in a coordinated way, and it might end up, the food and drink might end up going down towards the lungs. There's a risk of aspiration and pneumonia, so that's something we definitely want to pick up on straight away. Emotional health. So patients can often feel quite low when they first come home from hospital. It's a big crescendo of their leaving hospital, and then they get home and they realise this is really tough. So I would say that's quite normal, but if that continues on, or if there's any expression of ideation of suicide, that needs to be brought up with your senior straight away and then on to the GP. Also, we need to look at pressure risk from seating or splinting, and maybe thinking about the manual handling risks for his wife. So if his wife is at home with him, are there any manual handling risks? Brilliant. Okay, here's the next question. So what would you assess in your objective assessment? So your normal objective assessment markers, and then what specific areas would you assess for a patient post-stroke? And again, any safety areas to assess. So away you go, 2 minutes.
All right, let's get those answers coming in that chat group again. Obviously, I can see the answers because I've got the slides, so that makes it easy for me. So some of you already come up with some great ideas. You've mentioned sensation. So if you've mentioned asking in your subjective, how might you measure that in your perhaps objective assessments? You already mentioned things you'd expect to see a weakness. How might you assess that? You've got some hints that we were talking about: stairs, walking, mobility, any sort of function. Yeah, we've got some great answers coming in. Perfect. Myotones, dermatones. Yeah, very good. You're probably better than me if using your myotones and dermatones. More of a generalized assessment. So stroke, you might not be so specific in your myotones and dermatones, but the other two might chip in a bit more. I might be using more specific ones in my spinals, and in my strokes a little bit more generic. Cognitive and perceptual deficit screening. Yep. So again, you may well be picking up, or they may have articulated in your subjective some issues, and you may well be referring on to maybe OT versus doing your own cognitive screening, but certainly some perception screening you could do. Transfers, definitely 100%. Tone, yes. Coordination, sensation, muscle strength, function, yes. We are good at analysing all movement patterns, so that would be great. I just want to see my patients moving. Again, got some very exciting reflexes you're looking at. I'm going to probably put my foot in it and say, I probably don't look at reflexes, but again, this is a good Q&A at the end. But again, we've got some central nervous system we're looking at. Strength, balance, Romberg's, light sensation, muscle tone, coordination, proprioception, gait, tone.
Wow.
Cranial nerve exam for the arm. Again, I may not go too in depth with things like, again, spinals, where I'm thinking my cranial nerve specific assessments, myotones, dermatomes, stereognosis. Yeah, might be bringing that in. Vision, hearing, might be asking more than me assessing. Again, my laziness is coming out here. I'm cutting myself short here, what I maybe should be looking at. So yeah, lots of sitting, standing, moving is probably where I'm probably aiming at. So yeah, back to you, Alice.
Brilliant. Thank you for those brilliant answers. Yeah, it's putting us all to shame. So here are our thoughts. Again, with the same kind of colour coding. I'm going to be specifically thinking about the blue responses here. So you're all brilliant and picked up on coordination and efficiency of movement. So we really want to look at that motor control, because motor control is influenced by so many different areas working together. So we have to have our voluntary control and also our perception and sensory and everything working together to get that timing. And that's when you might see those deficits come out. So yeah, you mentioned about tone. So looking at hypotonicity or hypertonicity, hard words to say, sorry. And maybe thinking about any triggers for this. So you might see, so for example, if somebody has a UTI, you might see some evidence of hypertonicity. So you don't want to necessarily go down and medicate them for that unless we've taken the trigger away. So it's definitely worth looking at some triggers. Sensation and proprioception, I think you both said that, or the answer said that. And spatial perception and body awareness, and you might look at somebody's midline orientation. So sometimes they can be a little bit off midline, so that's something to have a look at. Vision, you might think of, you might ask them about their vision and look at to see whether they've got any homogeneous hemianopia, which is great, with great words. So that's where half the vision is reduced on both eyes. And you might look to see whether there's any symptoms of vertigo or nystagmus, but that's unlikely in an MCA. You might see that more in a posterior cerebral artery. And if that were the case, you'd probably have a separate vestibular assessment for that. So going to the safety questions, we definitely would need to have a look at balance, objective measures for balance and risk of falls, and thinking about risk assessments for that. We want to have a look at the appropriate use of aids and the splints and whether they're being used effectively, and whether there's any manual handling risks. We want to really think about the neglect of the left-hand side causing bodily harm. So if that left arm is hanging down over the arm of the chair, it's pulling on an already vulnerable glenohumeral joint. So you want to make sure that we're not causing any more harm. We want to think about whether there's any risk of shortening or contracture of the finger flexors. So are they getting tight and those fingers digging into the palm? And we certainly want to think about the pressure areas, especially the buttocks, because if somebody did develop a pressure sore, that would limit their time that they can sit out in their chair or their armchair or wheelchair, and that reduces their time to engage in meaningful rehab. So we want to be prophylactic and not get them to that point. So make sure that that's covered already. So all these things you would liaise with your senior again, and you check for your policies for risk assessments, and you would take it from there. So moving on, so we've covered the subjective and the objective assessment areas. So now, which outcome measures would you choose to use? And this is just a really nice quote that is from the National Clinical Stroke Guidelines in 2023. And it says, the measurement of function is central to the rehabilitation process. So it is really, really important that we do take these outcome measures at baseline, because that gives us an indicator as how a person is progressing. It's a good motivating tool for patients, and it gives us information about how we're doing and how our service is doing. So outcome measures are really important. So fire away, 2 minutes from here.
Right, well done, team. Have a think, pop some things in the chat. So the PASS, interesting. So is that the postural assessment scale for stroke you're referring to? Berg balance, good one for overview of the balance, brilliant. Modified Ashworth scale, looking at spasticity. Berg balance, again, it's when timed up and go. So you need a good 3 meter space for that one. That's quite a good one for out in your patient's lounge if they've got the space. 6-minute walk. Patient specific. Functional scale. The HAD, so looking at anxiety, depression. So if you're working in a community stroke team and you're doing a generic assessment across the team, you might be involved in doing the HADs. The ARAT, looking at that for the upper limb. Bartel index, good one for looking at function. Nine-hole beg test for looking at dexterity of the hands.
Brilliant.
Genetic, brilliant. Okay.
Shall I move on? So you've got loads of outcome measures that you came up with, many that I haven't come up with, so that's really good. I mean, this is just a long, but by no means all-inclusive list here. So some of which are more specific to neuro patients. So I'm just going to talk a little bit about a few of them. So the Nottingham sensory assessment. So if you're from your objective assessment, you have identified that there are some sensory issues, you might choose to then go and do the Nottingham sensory assessment to get a little bit more information, because that gives us a bit of a deeper dive into sensation, proprioception, 2-point discrimination and temperature. So it's quite useful. The star cancellation test and clock face. So that's where there's a piece of paper with stars on, and they have to cross off where they see the stars. So quite commonly, if there's left-sided neglect, they might miss the stars on the left-hand side of the page. Or you might ask them to draw a clock within a circle, and they put numbers 1 to 12 on just one side of the clock, which is quite a significant sign of neglect. So tone, I think we talked about that. You're quite right. Using the Tardieu or the modified Ashworth scale, and to be honest, tone is a whole different lecture that we can talk about another time. The armour and Lego, I really like using these. There's a self-perceived questionnaires. So they ask the patient to talk about how much they're using their affected limbs and this present time. And it's a really nice way to get a baseline measure and then looking ahead. And then finally, I would say the photos and videos with consent, very important, is a great medium for baseline measures. And quite often I get patients to use their own phones, so that then they've got a record of their own progress, and then they can send them with their consent on to you and to your work phone. And obviously you have to follow your trust or company policy, but it's a really nice way to keep track of progress. Okay, I think that's all I've got to say on that one. So now we have all this information, we can start pulling the picture together a little bit. And I think many of us use the International Classification of Function, which was produced by the World Health Organization in 2001. And here's an example I've just put in upper limb deficits following stroke, which you can see up in the health condition box at the top. And then you can see the body functions is more about their impairments, so they might have reduced power or spasticity. and how that impacts on their activities. So it might be ADL of writing or typing, as we talked about earlier. We might think about the environmental factors that might impact on a patient's journey. So whether they've got friends and family to support them, whether their house is appropriate for rehab or whether it's very cluttered. We might think about personal factors, so any other comorbidities, their age, things like that, that might impact on their journey. And also thinking about their wider roles in life, so their participation is either in family or recreational activities or work and hobbies. So it just gives us an idea of a patient's rehab journey ahead. And this helps us guide them to create their goals. So it's very, very important. We as physios don't push what we think they want to achieve. It really must be a patient-led experience of them owning their own goals. And it might be sometimes that they come out with a long-term goal, and as physios, we have to enable them to make those stepping stones to achieve that long-term goal, but that's part of our role. So it can be a really important part of our treatment intervention to provide a journey forwards for patients to work towards. So I can't really talk about stroke and stroke rehab without neuroplasticity, and this might come up as a question in one of your interviews. So neuroplasticity is the mechanism for recovery after brain injury. And this diagram by Marion Medina in 2023 shows a brain with an infarct. So the first picture, A, has the red cross where the infarct is. And initially what happens is the brain is so clever, it finds a compensatory strategy. So on the other side of the infarct, the other hemisphere, we usually see an increase in activity to compensate for the loss on the other side. But as time goes on, and hopefully with our amazing neuro rehabilitation strategies, the area that was damaged by the stroke starts to recover, and we see a functional recovery of that ipsilateral corticospinal tract. And the contralateral activity decreases. So this then dampens down. It's what we call pruning. And then finally, we get to see the interhemispheric functional connectivity returning. Okay, so how do we promote neuroplasticity? Well, whilst I appreciate that some people are opposed to animal research, some of these early rodent studies gave us a load of evidence about the influence of enriched environments. So what they did was they put mice into two different cages. So one cage had lots of different interesting ways to exercise with balance and coordination and wheels and ladders and all sorts. And they changed these quite often. And they also added in new animals into the cage, which was interesting to increase their social interaction. The other mice were put into a very simple standard environment of just food, water and bedding. And then after their death, their neurons were studied, and the appearance of the mouse brain in the enriched environment had significantly more neuronal sprouting and new synaptic connections, which they deemed to be as neuroplasticity. So this theory was then explored a little bit more by this study by Vive et al. In 2020, and it's in your reference list, so you can have a little look. But it shows that there were significant improvements in patients that had a more enriched task-specific therapy group, and this led to clinically meaningful improvements for patients with chronic stroke. So this is, it had some limitations, this study. It was a very explorative study, but it has great implications for what we could be doing as physios. So what does that mean? It means that we need to be clinically creative. So we need to think how we can enrich our patients' environments. So we can adapt their exercises with different planes of movement or different postural sets. We can adapt the environment, so we can think about working in different rooms of the house or in the corner of the kitchen, or even getting a patient up to, one time I've got a patient up to Waterloo because he had to walk across that concourse to get to work. So we can change the environment to make it more enriching. And we can also adapt the task, so we can make it really salient to that person. So for example, if this man used a computer mouse with his left hand, so we could work with that within his therapy sessions to make it really meaningful to him. Okay, so let's presume we've done all our assessments, outcome measures, and this is our problem list that I'll read through quickly. So he has a left sublux shoulder. He has grade 2 muscle strength in all his affected muscles in the upper limb. He has some spasticity, let's say a motor assessment scale of 1 in elbow, wrist, and finger flexors. He has a left foot drop and some clonus in his gastrocnemius, in his calf complex. And he has grade 2 muscle strength in all the muscles in his affected lower limb. He has sensory and proprioceptive deficits and a mild neglect on the left-hand side. His Berg balance scale was 34 out of 56, and he was furniture walking and unable to do a timed up and go because he was unsafe. Bladder issues were waking him up 5 times a night, and he reported feeling very low. So he also had a poor understanding of the reasons for his stroke. So what is your priority for treatment? So we'll crack on and see if you have a few thoughts about what you might want to treat first. Okay.
Right, so let's have a look. So education, someone's put it up already. So to help him improve the understanding of his condition. Yeah, okay, that's good starting point for people to understand the importance of where to start. Any more thoughts from there? If you're that person, what do you think is going to be causing the most impact for you? Preventing complications, spasticity of the upper limb, the flex to prevent contractures. What sort of things are shouting out to you here about this person? What's having an impact on their daily life? So balance, risk of falls, ability, the safety issues. Yeah, looking at safety first. Absolutely. Yeah. Lack of sleep due to the bladder. If you are up 5 times a night, how functional are you going to be in your day? That's a really important starting point. Absolutely. Safety. Someone's put consider an AFO. Interesting. Bladder issues because of the impact on sleep. I agree. Walking aid is not furniture walking. Interesting. Something to come back to. Safe mobility, 24-hour postural management. Absolutely. Working on tone, upper limb impairment. The patient feeling really low. Yeah, absolutely. That would be one of my big concerns too. That impacts on so many things, doesn't it? If you're feeling low and you're not sleeping, that's going to impact on everything else. What do you reckon, Alice?
Yeah, that all sounds brilliant. Yeah, I completely agree. So we had a think about this, and we identified the risk of falls was probably something that we'd really look at as a priority. So we might want to think about working on the left lower limb for core strength and core strengthening with weight bearing. You might think about a staggered sit to stand exercise. You might work on the left upper limb and standing in that corner of the kitchen unit where somebody can feel safe and secure. And we might think about building those programs with introducing load and increasing resistance and changing reps and speed, just really depending on whether you want to focus on strength, power, and endurance, depending on what goals they want to look at. So thinking about orientating to the left and the midline, and as you quite rightly said. So maybe providing a foot up splint or an ankle foot orthosis, or maybe functional electrical stimulation, which can help reduce the foot drop and decrease the risk of falls. Might think about providing an aid of some sort, perhaps a tool pole. And I'd probably give them a home exercise program, only 3 exercises, not too many if he's finding it difficult to sleep. And then maybe a calf stretch, and thinking about spasticity management if that continues to be an issue. So again, you quite rightly said about education, advice and support. So we want to support with active listening skills, understanding the concerns and building that therapeutic relationship, giving education about stroke and how recovery occurs after stroke, and maybe providing more information for support. And if you're concerned, then you would definitely upscale that to your senior and onwards to a GP. And then upper limb management, I think we talked about that as well. So 39% of people with stroke have post-stroke shoulder pain, and that can lead to poorer outcomes of the upper limb. So if we can prophylactically prevent this, then that's perfect. So we might think about working on strength of the core, the upper limb. We might think about weight bearing onto that upper limb for more sensory and proprioceptive inputs. We might think about positioning the arm so it doesn't hang down, and we get lots of visual impact of that arm. And then thinking about the shoulder support, maybe providing a support of some sort, and functional electrical stimulation. And then at some point we'd think about cardiovascular training, which would be brilliant to involve a kind of a love for fitness and activity. And we want to make our sessions really engaging. So we want our patients to move more, which I think is the message coming across, is moving. Okay, so here are the National Clinical Guidelines for Stroke that were published in 2023. You can read this later because there's a lot of information here, but I've just highlighted in blue what's a little bit more pertinent to our case study. So talking about task-specific, repetitive, intensive exercises or activities for increasing strength, thinking about balance training, thinking about how to get up off the floor after a fall. And they talk about ankle and foot orthosis and functional electrical stimulation that we talked about. And thinking about having some self-directed therapy, so time outside of our therapy sessions, and that cardiorespiratory training, which we've talked about. And some of the other evidence-based treatment options that the National Stroke Guidelines recommend are constraint-induced movement therapy, which we can talk about at the end if we have time. Mental practice, mirror therapy, outdoor mobility, pain management, spasticity management. So there's references of that in your reference lists, as is splinting. So splinting isn't routinely advised, but on occasion that is useful. Fatigue management, I think someone put that in the chat, so that's brilliant. And eventually looking towards returning to work and vocational rehab and driving. So final question, we're running out of time, but which other MDT members would you involve?
Right, this is going to be easy because there aren't masses. So we've got down here OTs, speech and language therapists, yes, OTs, yes, rehab assistants, brilliant, don't leave them out, they're like your best friend. Speech and language OTs, community nurse, again, nurses, consultants, family, the patient, yes, very important. Stroke support groups, excellent. Continence nurses, yeah, picked up on that bladder issue, that might well be where we're heading. So the low mood, the motivation, definitely outside of our scope of practice. If someone's saying they've got low mood, but we need to accelerate where that referral is going to. Support workers, nurses, stroke association. Yeah, I think you've covered everyone. Best response so far.
Yeah, I would agree. You came up with all the answers. Here's the list we came up, which I think we probably covered everything. Maybe the tone management clinic that we might refer on to for if that spasticity or hypertonicity becomes an ongoing issue. Gait lab, orthotics, continence nurse to address the bladder issues. And sometimes you can actually put Botox into the bladder to reduce the frequency if required, and the carer support group. So just remember about the wife and whether we can support her a little bit more as well. So I think that's it, folks. So thank you so much for listening, and all your input's been brilliant, and thank you to Caroline and Kim for supporting the chat. There are references at the end of the presentation for you to draw upon, with some clinical guidelines included. And it sounds to me like you've got all the answers already, and hopefully this webinar has confirmed some of your knowledge or filled in some of the gaps. But we wish you every luck for your future interviews. So if you've got any questions, please do. I think we're a bit over time, and we can always answer them separately afterwards.
Alice, Kim and Caroline, are you happy just to answer the couple of questions that are in the Q&A? And if people need to go, they can go. Alice, would you just move us on to the very last slide, the Menti slide, just for people to give their feedback?
Yeah,
that would be great. And the slide before that we will be able to share with you is just reminding you of the CSP graduate support package. So please do access that as well. But if I can go back to you guys, just to look at those couple of Q&As that we had, and if students and graduates are happy just to complete the Menti to leave us some feedback as well, whilst Caroline, Kim and Alice are replying to those. So can you see the Q&A, or would you like me to call it out?
If you could call them out. I can't see them.
No worries. When bringing up supporting evidence for treatment options, such as task-specific training, are we expected to critically appraise the evidence briefly to show a more holistic view instead of just naming studies in interviews?
Well, if you can do that, I think that would be fantastic. I'd be very, very impressed if I was an interviewer and you were critically analysing papers. In reality, I'm not sure that there'll be that much time, but yes, I think that would be a great idea if you could. Yeah, fantastic.
And Charlotte, I'm aware you're on the call as well. Would you add anything to that, or do you want to type anything into the Q&A? Might not be able to unmute herself. We'll leave her type if she is. So thank you for that one. And Samia asked, when prioritizing problems in a neuro case, should safety factors such as cognition and insight be addressed before function during the interview? And when discussing management, well, I'll ask that first question first. So when prioritizing problems in a neuro case, should safety factors such as cognition and insight be addressed before function during the interview?
Does anybody else want to answer that one?
Oh, Kim, you're on mute.
How's that? Okay.
We can hear you now.
Yeah, absolutely. The safety aspects is your number one go-to. Lots of the other things can come out on future treatment sessions. So if something like the cognition and insight is having an impact on their function, then that's part of where you need to begin working with your team members, raising that as a concern with your OTs and your nursing team. Yeah, absolutely. That's where I'd be starting to.
Lovely, thank you. And then Samia had another little bit to her question. And when discussing management, does integrating MDT input within goals risk limiting how clearly I demonstrate my physiotherapy specific knowledge, or is this considered best practice?
I mean, I feel like, stroke rehab is such a holistic area of physio, and physio has to be integrated across such a team for stroke. We're not talking about just, a joint, a muscle group. We're talking about the whole person here. I think that's where you have to be really linked in with your interviews, kind of understanding that wider impact on that person.
As I said, I would add to that and just say that the only way you could get around that in an interview question is sometimes perhaps they might be referred to physio first. So you could perhaps say you would obviously be liaising with the other MDT members, but considering that referral has landed on your desk first, you're sort of going to plough in, acknowledge where other MDT members need to step in, but you 100% know where you would go from a physio perspective.
Yeah,
Thank you.
Yeah.
How updated are we expected to be on current guidance, I would presume guidelines as well, on common neuro conditions treatments, and are we expected to embed this in our interview responses?
I think we should always be shaped by the clinical guidelines that we have. So I think it would be expected that you know the main clinical guidelines, which I've put in your reference list. So yes, if you can, I think it would be good and well worth your time to have a read up on those.
Lovely. I have a query. How would prescription of appropriate mobility aids be done if patient mobility was limited between a Zimmer frame, return via Zara Steady as an example?
Do you want me to? So I can see that one. So when we see a patient in the community, sometimes they've gone home with a specific aid. So I think in that example, perhaps the patient's been sent home maybe with a Zara Steady, and that's what is considered safe. But perhaps I think what you're trying to say is as you're doing your rehabilitation with them, you're thinking actually they're too good for the Zara Steady, and I would want to now look at them with a Zimmer frame. If they didn't have one, then that's when you would, in the NHS, be able to go back to your sort of stock or order. Obviously, we're all in the private sector, so it's somewhat different, but you would then get equipment and take it to the home, and then you would look at trialing that. And then it's always bridging that gap between, yeah, we've looked at something like a Zimmer frame with a patient in physio, but then that being handed over to family and carers, and that's when that whole MDT working comes into play, because there's a lot of paperwork, and ensuring that everyone is safe and everyone is comfortable with any change, until eventually you get to the point of saying, yeah, that's Zara Steady, can go back to the storage, and now we're 100% using that Zimmer frame all the time. But as a physio, that would be your role.
Lovely. And then the last one's a biggie. I don't know if you have it left in you. Can we chat about the differences with assessing myotomes, dermatomes, and reflexes in stroke compared to a spinal injury of the neuro assessment in the MSK context?
So I popped that in Q&A based on some of the answers for the objective assessment that Alice had proposed, and there was a few people that were sort of chatting about myotomes and dermatomes, and would we be checking around reflexes? So I think this is a really interesting thing for us to chat through, because I think this really kind of comes back to our core understanding of the neuroanatomy and why we do that or we would not do that in a stroke. Caroline mentioned, if we're working with people with spinal cord injuries or your peripheral nerve injuries, or you're in an MSK outpatient setting, and your neuro assessment is very slightly different in that you are looking at your reflexes, you are looking at your dermatomes and your myotomes, because you're looking at the different segments from the spinal cord or those peripheral nerves, or in an MSK setting, you're sort of ruling out any of those sort of potential impairments, as opposed to in stroke or brain injury, when you're looking at kind of much more central nervous system disorders, then you're much less likely to have very specific impairments around a particular myotome or a particular dermatome. And in terms of assessing reflexes, again, in your neuro assessment in an MSK setting, then you're going to be doing your reflexes because you're trying to sort of rule out all the nasty things going on. But in our neuro rehab, in our stroke rehab world, we're expecting everybody to have different reflexes. That is part of their condition, and us as physios doing that wouldn't necessarily be the priority, because what does it mean? What does it change for us? What's important is what is the impact on their function. So that's where we would always be going for, the priority of our assessment is around function for that. Does that clarify things, or Alice or Caroline, you got anything else you want to sort of add to that?
I think I would just echo what you both have said, that yes, I I wouldn't routinely check dermatomes, myotomes, reflexes with a patient who's had a stroke. I would definitely be looking more at their risks and looking at how we can return that person to function and optimize their living.
It makes our life easier.
Yeah, yeah. And this Naomi, who's on the call as well, we work together. Naomi's an MSK physio and I'm a neuro physio. We work together quite a lot. In the neuro physio world, we rarely have a reflex hammer to hand because we know all of our patients are like.
That's me, sorry.
We know our neuro patients are very likely to have changes on the reflex test, and that's almost normal for our neuro world. Whereas in your MSK world, you're looking out for people that you don't want them to have reflex changes. So you're using that to rule out the nasty things. So that's one of the differences between our assessments.
Brilliant. Thank you so much for that extra little bit of wisdom at the end as well. I think that was really helpful and I think would make an excellent interview question for anyone who's listening in that might be thinking about interview questions moving forward. So thank you for those who have stayed on the call with us. It was great to have you along tonight. Thank you for providing us with feedback and a massive thank you, yes, to those who have already started clapping. Thank you to Alice, to Kim and to Caroline for their time and their energy giving you this tonight. We hope you found it useful. Remember the recording and the slides will go up onto the CSP Southeast Coast Regional area of the website in the next few days. And we have one more lined up, which is one that will focus on Parkinson's disease, and we'll be getting that date out to you soon. So thanks very much, everyone, and enjoy the rest of your evening.